So I'll be presenting. My name's Jeff with Rishma, who has been my co-lead with much of the integrated care work in East Toronto. And wanted to share with you the East Toronto Health Partner experience. And we've entitled the talk a collaborative co-design approach to implementation. So who are we in East Toronto? We're about 100 organizations, primary care, home care, hospitals, social service organizations with many patients, caregivers, community advisors included. We serve about 350,000 people in East Toronto, have a lot of diversity, 21 neighborhoods with about 50 languages spoken and 5 high priority equity deserving communities, of which Taylor, Massey, and Thorncliffe Park are 2 of our largest. So certainly this group appreciates the challenge with chronic disease management and the impact it has in Ontario and the individuals suffering from chronic disease. We know that individuals with any number of the chronic disease listed in the priorities for Ontario Health, their diseases are exacerbated with these intermittent episodes of increased health need and frequent transitions between hospital and community care. And I think this really hit for me when we were doing some of our interviews with clients, and one of them described it as feeling as though after they left the hospital, they were in a choose your own adventure book. And really that lack of integration between those transition points allows really an opportunity for integrated care to make a difference. So this led to the excitement when we were given the opportunity to develop integrated care to try and see if we could figure this out for our clients.
I'll talk about how we try to approach ourselves and really grounding ourselves in East Toronto Health Partners' core values. So we looked at East Toronto Health Partners with our partners, said, let's do some guiding principles. And the guiding principles is what we look at, and we still go back to ensure that as we design, implement, keep on iterating our integrated care pathways, we ensure that our guiding principles are our core of our foundation. So that's patient-centered care, health equity, really looking at evidence-based standards. So we looked at our clinicians, our specialists, our primary care, asking them what evidence-based standards do they like, they are using. We had a plethora of different evidence-based guidance. And so we really buckled down on the Canadian Thoracic Society, treatable traits, and the Canadian Cardiology Society to have that as some of our foundation to our integrated care pathway. And as Jeff mentioned, those seamless transitions, really looking at transitions and self-management to really empower our people in our community having these chronic diseases. We ensured that we had everyone's voices at the table. So our patients, our families, our caregivers with lived experience, our primary care, our specialists, our home care, our community providers, and then really looked at technology and ensuring we had digital experts at the table. Our engagement include 150 different individuals, different people from across the different sectors, making sure that all voices were heard. And we really wanted to do some meaningful co-design. So bringing our patients and our partners together, we had different workshops, we had design workshops, really looking at what is the art of the possible, what do we want to do? We further broke down into working groups, really trying to understand what is the need, what are the gaps, and what do we want to do at East Toronto Care Partners to really understand what integrated care pathways means for us and how we're going to position them, and really putting that patient and caregiver, those people in our community, at the center of all our engagements.
So we felt it was important to do that work with our community to try and come to this consensus about where we go next. And, we wanted to try and operationalize the quintuple aim. And really, at the end of it, we wanted to build a lasting impact of integrated care, something that would be sustainable, people-driven, something that fostered and built internal capacity and delivered long-term value. And we thought it was important to come together to this conclusion because from here, we had to make some important next strategical decisions about where we went. We had to make the decision, we use some of the existing kind of quote unquote off the shelf solutions for integrated care, or do we try and build an engine so that we could insert a multitude of future integrated care pathways? Again, our future vision is that we build this thing we've called EastCan, and we insert integrated care pathways that might be different disease states to get to an end goal where all care is better integrated, not just for specific disease states. And so we made the decision that we would spend the time up front to build our own East Toronto solution called EastCan, rather than use some existing solutions and hire those to do our work.
So with that vision and understanding that we were going to build a program, starting with chronic diseases, but make it scalable. Make sure we're building an engine that can do a variety of integrated care pathways, but we'll start with where we had an opportunity with Ontario Health, with COPD, CHF. And what we did is really did a bunch of journey mapping. So looking at our people and doing their journeys with their chronic diseases. So we were able to do quite a few journey maps, focus groups with our people in our community, and understand where the gaps and their needs were, and really listening to the voices of those people. And then we worked with our partners to understand what programs and services are offered in East Toronto, where are our people getting their support for chronic diseases. So we did a partner asset mapping, which is really mapping out our programs and services, helping us understand what can we leverage, how can we leverage existing into the program, and how do we feel about building where there is no capacity or there's gaps. So really understanding current state to help us enable us to make sure that our patients have that integrated holistic care. So we did that in our co-development. So our model that we came to after all the co-design, co-development was really called EastCan, as Jeff mentioned. And some of these features are having frontline staff, so our clinical care facilitator really doing some case management, our access administrator who is doing service navigation, making sure patients get the services that they need to support their journey, remote care monitoring and post-discharge support. And again, as I said, holistic self-management. So we're really looking at the medical part and medical management and medicine management, but also social determinants of health. Working with our people and our patients to understand what are their goals, what do they want to achieve, how do we empower them for self-management. We built in case management and progress reporting, so progress reporting with our people in the program. So ensuring they understand what are their goals, how are we working, how are we supporting them to get to their goals. Our progress reports are done on 1 month, 3 month, 6 month, 9 month, and 12-month basis. So really ensuring that we are working with our patients. We have digital enablers in place using our electronic medical records, and also ETHP has a shared care planning platform. So leveraging our shared care planning platform for care planning. Service connections using our asset map that we just mentioned in a slide before, and we have coordinated team-based rounds, all part of the program. Also part of the program, action plans. So for medication management, action plans for exacerbation management and repeat follow-ups. We also enabled a lending program for equipment for patients to be able to have equipment to monitor their chronic diseases, specifically for COPD, CHF. That includes a blood pressure monitor, oximeter, scale, and also an e-reader that has patient education materials on the e-reader. So just at the bottom here with our visuals, just to show how we did this. So we really wanted to clarify the vision and what was our ideal future state. We wanted to build that engine. We wanted to really leverage data and evidence-based guidance. We wanted to build out our program, but we wanted to do it in a phased approach. We really felt that we can start small and keep on working upwards. So we started with COPD, we started with hospital admissions, we moved out to CHF, and then we moved to community primary care referrals. And really a core foundation of our program is to test and iterate. So really build it, test it, iterate it. So constantly looking for improvement opportunities and keep on that rapid cycle improvement. This is how we just built and implemented. So I won't go through this in detail, but we really wanted to understand how we're going to build our engine and then how we're going to implement it. So looking at the key features that we needed and the key parts of project management, the processes, tools, our staffing, our technology, looking at communications, and ultimately change management as we implement it. So we were able to launch East Toronto Care Network. So we're very proud of this work. It's really the service delivery arm of East Toronto Health Partners. There's our website for future reference and just showing you some of the patient information through our integrated care pathway folders and then our equipment lending program. This is a visual of East Toronto Care Network, so I won't go through this in much detail, but these are the features of the program. So right now we have our integrated care pathways with our clinical care facilitator. Our clinical care facilitator really working with that circle of care and the different people and providers that are part of that care plan. And we also have rounding tables. So rounding tables is really for people with unmet health and social needs. And they are brought to the tables, they occur about twice a month with different providers at the table. And it's a case management, and we're looking at case rounding to really help support people who are not getting what they need or having troubles or challenges, barriers within their care plan. Using that, we also wanted to map our health quality Ontario standards. So we looked at all the health quality standards and said, how are we making sure we're check marking all these standards within our pathway? So this is just us putting our stars with our health quality Ontario standards into the pathway and ensuring that we're meeting all of them. And there's our CHF, mapping out our health quality Ontario standards for CHF as well.
So in keeping with our desire for iterative improvement, we use an operational dashboard at our Q2 weekly clinical and operational team meetings. We review the number of people who have been approached to consent. Again, we are consenting people at present from hospital admission with one of COPD or CHF, and are now having people referred in from more community-based sources, primary care and other specialists. So we're able to review how many were approached, how many consented, how many were enrolled. We can also review escalations and ED avoidance. And then particularly important, look at the top services that are being requested by our interactions and how do we potentially build better systems to make sure those needs are met. Appreciating that many of the metrics that HSPN and others are looking at are going to take time to hit readmission rates and such. We did want to make sure we collected patient stories. And, when thinking back to our patient-centric building, we wanted to ensure that we captured these adequately. And I won't read all these explicitly, but, just looking at the first patient, we often forget about palliative care in chronic disease management, but it is one of the health quality standards that's critical. And it was a COPD patient who was really struggling, recurrent hospital admissions, which was not ideal at their end of life. And we were able to facilitate in-home assessments and have subsequently prevented readmission, which has improved their end-of-life care substantially. So just in closing, we feel we've built a scalable solution, and this has improved East Toronto's system capacity. We are hoping to expand to future pathways. We did do planning for lower limb and hoping to introduce that. We were lucky enough to receive some funding for a ventilation program. And again, our desire is to pull everything into this operational arm of East Toronto Health Partners. So we pulled the post-ventilation program into that as well. And then desires for mental health and palliative care as well. The hospital has redone its strategic plan. Integrated care is really prominently present, and ETHP is refreshing its strategic plan. And again, integrated care is a strong vision for the entire group of partners. In addition to the evaluation that's being done by the ministry, we are also doing patient-provider journey mapping just to stay true to our vision of doing what's right for the patients and providers, and also looking at healthcare utilization more locally compared from the previous temporal past to present after enrollment to see if there's a change in healthcare utilization. So thank you everyone for your attention, and we'll conclude our presentation there.